Hello, and welcome to the CAP Today webinar for Thursday, October 13th. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host and moderate a question and answer session after our formal presentations. Today's webinar is entitled Optimizing the Management of Patients with Solid Tumors Using a Tumor-Informed Approach for Molecular Residual Disease Assessment and Monitoring. Today's very important webinar is made possible through a special educational grant from Natera. We want to acknowledge that grant and thank Natera for their help in bringing you this very important session. Today's speakers, and I'll say more about them in due course, are both medical oncologists in Southern California, Dr. Gregory Botta at the University of California in San Diego, and Dr. Noam Z at the Cedars Sinai Medical Center. Now, before we begin, I'd like to go over some housekeeping hints that I think can enhance your enjoyment of today's webinar. First, we often suggest that you go ahead and refresh your browser. Secondly, I want you to know there's live help available throughout today's presentations and webinar. If you look in the bottom right-hand corner of your screen, you'll see a number, 858-345-5916. You can call anytime for technical assistance, either with the website and that platform or with the audio. In addition, you'll see below the slide deck a section labeled Q&A. There you can also ask questions about technical problems or content, and you'll get immediate help. But of course, the Q&A box is really intended for you to be able to make comments and ask questions throughout any point in today's webinar. And as I said before, when the presentations are finished, I will go ahead and moderate a question and answer session in the time remaining. I want you to know that you'll be able to repeat this experience by seeing the full slides and full audio in about a week at captodayonline.com. You will likely see some follow-up email from our sponsor and from us, so I wanted to alert you to that fact. Finally, it's very important that you know that CAP Today does not endorse any product or service that may be mentioned in today's webinar. And of course, any comments of mine are purely personal, not to be taken as the policy of CAP Today or the College of American Pathologists. And now, we'll go on and begin today's very important webinar. Our first speaker, and I'll introduce both of them once again. Our first speaker is Dr. Gregory Botta. He's an MD and a PhD medical oncologist, associate professor at the University of California, San Diego Health. And then our second speaker is Noam Drazin, MD, medical oncologist with Cedars Sinai Medical Center. We're very grateful to both of them. They've got a fascinating presentation. And now I will ask Dr. Botta to go ahead and begin. Dr. Botta.
Thank you so much. Thank you for the introduction. I'm very happy to be here with Dr. Drazin. Today we're going to be talking about our patients with solid tumors and how we use molecular residual disease profiling or circulating tumor DNA to assess their disease and to monitor for any recurrence. And we're going to be discussing this along the backbone of the Signatera ctDNA molecular residual disease platform. And again, Dr. Drazin and I will be discussing this as we move forward and welcome any questions from the audience as we continue to discuss this in your question and answer box. Now, a big topic that usually comes into question, at least in my GI oncology patients, are these high-risk patients that come to us and they've had their surgery for their colon cancer, and they have some risk profile, and that risk profile may be that they have something like a T4 disease that has gone through the serosa of the colon. They might have perineural invasion or lymphovascular invasion. And these patients may come to us and say, do I really need to get chemotherapy? And a lot of times we're left with a very long discussion. These are the discussions we have for our patients with stage 2 high-risk disease because there's no clear guidelines. The guidelines from NCCN say talk to your patient, discuss with them the risks and benefits of chemotherapy and the high likelihood of recurrence or not. And obviously for a lot of patients, that discussion is left with more questions than there are answers. So a lot of times I ask my other colleagues, and I would ask you at this time, how do you currently manage these patients? You talk to them about adjuvant therapy, but they have a lot of comorbidities. However, their risk is really high. And how do you come up with your answers to your discussions? And a lot of times it's meant with the possibility of just close surveillance. You know what? You did have a high-risk disease, but at the same time you have a lot of comorbidities. You already have diabetic peripheral neuropathy, or we know that you have a history of kidney disease. We don't want to provide any type of chemotherapy for you. For other patients, we might say, hey, guess what? There is a new way of determining your risk and determining if you really are a candidate for chemotherapy and how high that risk is. And that would be something like the circulating tumor DNA test, the Signatera test. In other ways, we can look at comprehensive genomic profiling, looking for actionable mutations, looking for things like RAS mutations or BRAF mutations and give a risk assessment. Or there's a lot of times where patients will evaluate us and we'll evaluate them by CEA tumor monitoring. Looking at their bloodstream over the course of months and seeing if there is a CEA, carcinoembryonic antigen, in their blood that enables us to determine if they're going to have disease recurrence. But we do know that CEA is very nonspecific. It goes up and down for a variety of reasons, and a lot of times it doesn't necessarily correlate with the patient's tumor at all.
Very good. So let's go put up our polling questions now to you in the audience. You've seen the questions. How do you currently manage your high-risk colorectal cancer patients? And you can see the answers as they settle out here. We've got quite a split decision. And we'll go ahead now and close that poll. And I'll ask Dr. Botta to continue. Dr. Botta.
Thanks so much. So yeah, we can look at the poll results here, and we can say that a variety of you, almost 50%, said close surveillance. Here's a patient that had high-risk disease. This patient had high-risk disease, and they are not a good candidate for therapy. So why are we going to even attempt to give it to them? And then in most of a third of the people here said ctDNA testing, and that's why we're here. Is, hey, you know what, let's really, even if we're not going to treat them, let's at least understand their risk profile. Let's understand if they're at high risk for recurrence. This may help me decide on their surveillance strategy. And others say, let's look at their genomic profile and look comprehensively. Let's not only get molecular residual disease, let's look at the BRAF mutations, KRAS mutations. And CEA monitoring, yes, CEA monitoring is a tool in our toolbox, but it's not necessarily a treatment decision algorithm that we should be using as a yes or no, a binary response. So, I agree with that. But yeah, there's a lot of notion at here, understanding that there's options available for evaluating these patients. Now, we do know that a lot of our patients are cured by surgery alone. These patients come in stage 1, stage 2, even our stage 3 patients can be resected and actually come into our clinic and say, hey, I'm here for adjuvant therapy, postoperative therapy. And I tell them off the bat, I said, listen, you could be cured from your disease sitting here right now today. I'm not going to take that away from you. But let's really get into the chances of that. Let's get into the risk assessment of that. And we know that if we add chemotherapy, we can reduce that risk that it comes back in a certain subset of patients, and that we know that giving them that chemotherapy is worth it. They can handle it. The complications or side effects are something they can get over, and in fact, we're reducing their absolute risk of having a cancer recur. But unfortunately, too, we know that there are some patients we overtreat. We give them treatment that they don't need. They're already cured. And then there's those patients that have a really aggressive disease. Those patients that no matter what we do, surgery, adding chemotherapy, they're going to recur. And we really want to know who those patients are so that we know to assess them and to surveillance them over time for other methods to help intervene. whether that's maybe a oligometastatic resection or maybe adding radiation. These are tools that we have that we can maybe pull out later on. And the idea is that with ctDNA, you can help substratify these patients. With the Natera platform, you're able to indicate if these patients have residual disease after their surgery, have residual disease after their treatment, are responding to their treatment, or in fact are relapsing on surveillance. And here's a patient case study that we can discuss. And it's something that I think that comes up in our clinic a lot, at least in my GI clinic. You have a patient who's 68 years of age. They have a T3N0, no metastatic disease, left-sided colon cancer. This patient has microsatellite stable disease, or MSI low. They're BRAF wild type, KRAS mutant, more of a run-of-the-mill type of T3 left-sided colon adeno patient. They do have some high-risk features, lymphovascular invasion or LVI, perineural invasion, PNI, but it's a low-grade tumor. It's well-differentiated. And guess what? They looked at 30 lymph nodes, and those lymph nodes were all negative. There was no perforation. There was no extension. So this is a patient that we usually commonly see, and they sit there and they say, okay, should I get chemotherapy? And we say, well, okay, if we think about this, you're under the age of 70, so the possibility of oxaliplatin comes into play. So we might want to think about that. We also know that, you're T3N0. You didn't have any lymph nodes involved. Those lymph nodes not being involved out of a sample size of 30 might mean you're totally cured right now. You may not need any chemotherapy. Well, we do know there's some high-risk features. There's the perineural invasion. There's a lymphovascular invasion. Maybe we just want to do Xeloda or capecitabine alone and try to reduce your risk that way. Or what we could do is we can get a ctDNA. If that ctDNA is negative, we can feel more reassured that there's no molecular residual disease. And in fact, we can maybe think about going right to observation. However, if that ctDNA is positive, you have a very high chance of relapsing in the future. And as such, what we would want to do is try to get some adjuvant therapy to reduce your absolute risk. So at this time, I'll leave it open to think about what you would do in this situation.
Once again, we're accumulating answers, although that's a little more of a bimodal distribution there.
Absolutely.
Dr. Botta, would you care to comment now?
Yeah, so now that we've ended this poll, you can see that most of you have thought about using ctDNA or molecular residual disease to help inform the next steps. There are some people who said, you know what, I'm just going to go right to observation with this patient. Of course, that's based on guidelines. But of course, the molecular residual disease is not only going to help you assess if this is a treatment decision, but it also gives you a risk assessment of this patient as well. And I think that, of course, with everyone on the webinar, that this helps substratify this patient population. It helps us understand them a little bit better so that we know what their risk assessment is, they know what their risk assessment is, and it also provides them and you with either reassurance in your decision making. And because of that, we want to try to explain how to use ctDNA, how to think about molecular residual disease as a decision-making tool in your practice. Now, when we think about clinical disease and we think about ctDNA testing for MRD, we need to think about it over time. We need to think about it when we are treating our patients, when they're getting their surgery, when they're in surveillance. The ctDNA can be used longitudinally. And the idea is that most of our patients will come to us with a high burden of disease at diagnosis. They didn't know about their disease. They just became diagnosed with it. We're already behind the 8 ball. And basically the idea is that in some of these patients, we would want to use neoadjuvant therapy to shrink it and to get to surgery. In some of these patients, we might just go right to surgery, some of these colorectal cancer patients. And in that case, some of them might actually be cured. So you can see here at number 1, if a patient needed neoadjuvant therapy, we could track their ctDNA and see if it goes down over time. Once they get their surgery, we can see if all of the disease burden has been removed out of their body. Then what we can see is that after that's been completed, that ctDNA is now tapering off and down. At that point, the patient may want to go on to surveillance, or they might be on adjuvant therapy. And during that time, you can actually detect that the patient cannot have any disease in their body. Now, the ctDNA continues to be observed over time, and all of a sudden the ctDNA starts going up. And although we're not seeing anything on imaging, our concern is that there's recurrence of disease. And in fact, there does come a point where the burden of disease builds again that the imaging is able to detect it. Now, the imaging is detecting it at an earlier time. It's not at the point where it was at first diagnosis. But at the end of the day, you can see that that treatment is occurring with the availability of chemotherapy. And as they relapse, the chemotherapy has started and the disease burden is going down. You can see that over time that patient now becomes refractory to their chemotherapy and their ctDNA starts going up. And just like you might be following CEA, you would be following ctDNA. And ctDNA can be used as a very sensitive and specific marker for that patient's cancer to be able to get them the appropriate treatment they need when they need it, to prepare them for additional treatment when they relapse, and to also not give any treatment when you're not detecting any disease, or maybe start turning down the therapy because they're having complications. So these things are all problems that may be helped rectified with the availability of having a very sensitive, specific test for that patient's tumor. Now, why do we use circulating tumor DNA for molecular residual disease? Why not use something like CEA? Why not use something else in the patient's blood like circulating tumor cells? Well, the answer is that cancer cells are releasing ctDNA into the bloodstream constantly. You can see here that this patient's tumor, located in light blue cells, is releasing the circulating tumor DNA into the bloodstream over time. And as we do that, it's very sensitive and specific for that patient's tumor. And basically what we're able to do is not only detect if there's cancer in the body, but we're detecting the blueprint of the cancer, the DNA of that cancer. And we're not even detecting a correlate like CEA, which may go up or down based on the cancer alone. What we're detecting is that patient's own disease in real time. And it's dynamic. It changes with our treatment. As our treatment works better, we get less ctDNA. And if the treatment's not working, we'll get more ctDNA. And we know that that is based on that patient's responsiveness to that chemotherapy or to that surgery. And in this case, what we're able to do is track that ctDNA over time as things change, as treatments change, as the patient is in surveillance mode. The Signatera platform is a platform where we're looking at molecular residual disease. And molecular residual disease isn't even minimal residual disease, meaning we're not looking for just the minimum amount that we're seeing on scans or that we're seeing in tumor cells in the body. We are looking at the actual DNA evidence of that tumor. And you have to remember is that tumor sample is a DNA thumbprint, and that DNA thumbprint enables us to track that cancer over time out of the bloodstream. And once that thumbprint, that DNA signature is found, it's static because those signatures are actually derived from the primary tumor. Each of the cells that develop after that will still harbor that original DNA of that tumor. They may get new mutations as they continue to grow and other cells progress, but at the end of the day, that ctDNA is being able to be tracked over time from that original primary tumor. And everybody who has that DNA thumbprint from their tumor, now when they check their bloodstream, we're looking for that DNA signature. And with that DNA signature, we're looking at a specific multiplex PCR that can be taken from their bloodstream over time. And as we check that over time, we can continuously look back and see is the tumor burden up, down, up, or down. And you can see here on the far right-hand side, we can see that there's a graph. And there are mean tumor molecules, or ctDNA. And that ctDNA, when the patient first comes to us, is maybe around 200. But then we give them treatment, whether that's surgery or chemotherapy or maybe even radiation therapy, and we can see that that ctDNA goes down. And we always want to see those open circles. We want to see that that ctDNA is negative and that that patient's treatment worked and that we cannot detect any disease coming back at any point in time. And the idea is that from that single tissue source, we're able to track that genomic profile over time, that molecular residual disease. And importantly, we are able to extract more information from that. Not only can you take the molecular residual disease from it or the ctDNA from it, you can detect actionable mutations. If you're already doing whole exome sequencing for the ctDNA, you can always think about getting actionable mutations from that as well.
Thank you very much. And Dr. Drazin, I know that you're on. Do you have your slide deck in front of you?
Yeah, thank you. Thank you so much, Bob, and thank you, Dr. Botta, for introducing the topic so very well and discussing this case. So, thank you, Bob, and thank you, Dr. Botta, for allowing myself and obviously Dr. Botta to present to you today. So, we're going to look at the oncology suite of products that Natera has available. Dr. Botta already introduced the Signatera platform, which we're going to be talking about in great detail today. The Altera platform below that is kind of the next generation sequencing offering that Natera has, which has both DNA and RNA biomarker testing, and Empower is the testing for somatic, not just somatic mutations, but germline mutations for patients' eligibility and cancer risks. I think now I have control over the slides. Let me try that. Okay, great. So thanks, Greg, for offering to assist. If things go down, I might ask you again. But in terms of the sample report, this is an example of a sample report of Signatera, which tracks the ctDNA dynamics over time. As you can see, it's measured in mean tumor molecules per ml. This one here shows that it's not detected currently. As you can see here, it's a longitudinal presentation from the original data point, looks like prior to surgery when there was an elevated level of mean tumor molecules in plasma, to then becoming negative and staying negative. So that's what we're going to look at, the longitudinal assessment. This is somewhat obviously unique to this particular platform in allowing both quantification of ctDNA measurements as well as following them longitudinally over time, which is extremely important when it comes to what Dr. Botta initially mentioned in following patients in surveillance mode, following patients for recurrence over time, or monitoring patients who received treatment in the metastatic setting, for example, once they've recurred, and seeing if there has been progress made in terms of treatment. So there have been lots of studies, as you can see here, both in colon and breast and lung and bladder and all these solid tumors. And all in all, we're not going to go into every one in particular, but in essence, really, really high levels of positive predictive value and negative predictive value. As you can see, your sensitivity exceeds 80 to 90%. The specificity, which determines our positive predictive value, in average is over 98%. And that's across the board, across solid tumors, including colon, breast, lung, and bladder. And there is Medicare coverage of all stages in terms of colon cancer. That was the first validation study that was done in this particular platform. As you can see here, the ability to detect the positive results in patients, which give you a lead time to develop actual measurable disease on scans and imaging. Going into a little bit further is the ability of this particular platform, both in bladder cancer and in colorectal cancer, looking at overall survival based upon circulating tumor DNA status in patients, both in muscle-invasive bladder cancer on your left panel here and in stage 3 colorectal cancer on your right. As you can see here, the differences in ctDNA negative and positive, and the ability to improve overall survival over time. It helps identify these high-risk patients, obviously, who would likely benefit from additional therapy. Top levels here are patients with ctDNA, so in the green and the light blue portions in both of these panels indicate patients who have negative ctDNA tests, showing very little in terms of benefit from adjuvant chemotherapy or chemotherapy. And then further down below, you have patients who have ctDNA positive, where there's a significant difference. Obviously, the biggest difference here in colorectal cancer in your right panel between the orange marker here and the black marker below, with MRD positive tests showing a significant improvement in patients who've received chemotherapy versus not. So it's a really an amazing platform to identify whether or not patients would benefit from adjuvant chemotherapy. It's also an ability for Signatera to assess treatment response early. So on your left, is the treatment working? So one of the earlier slides that Dr. Botta mentioned is following patients through time and to determine whether or not the treatment is working. As you can see here on the left panel in colorectal cancer, this is adjuvant chemotherapy response monitoring. Obviously, the top panels here are patients who've gone from negative to negative and from positive to negative, seeing significant improvements in disease-free survival and DFS, as opposed to patients that go from a negative ctDNA to a positive or remain positive, significant decreases in disease-free survival. On your right side, there's also some interesting and very exciting data on the immunotherapy side, showing incredible responses to immunotherapy, and if you able to clear ctDNA on immunotherapy, there's a significant improvement in overall survival. Actually, the data from this particular pan-cancer trial of 25 tumor types, 100% overall survival with complete clearance of ctDNA across the board. So let's talk a little bit about the foundation studies that led to the approval of this particular platform, and obviously in colorectal cancer has led to the approval of Medicare-based payments for this particular test. So this particular clinical validation study that was published in JAMA Oncology by Reinhardt in 2019 looked at patients and staged patients according to current TNM's criteria in colorectal cancer. The majority were stage 2 and stage 3 disease, as you can imagine. 795 plasma samples were collected. They were collected at a pre-surgical date, at day 30, and quarterly up to 3 years, kind of the standard way we have been monitoring patients now with this particular platform. This trial by Cohen that was recently presented at ESMO was real-world monitoring of circulating tumor DNA, which was done to accurately predict recurrence in patients with resected stage 1 to 3 colorectal cancer. It was a 417 clinically annotated cohort of all stages, stage 1 to stage 3 colorectal cancer. As you can see here on the right side of the slide, these are the numbers of patients with ctDNA-based MRD detection rates. Obviously, you see a lot more detection seen in stage 2 and stage 3 disease, which you would expect, actually, knowing the ability of tumor DNA to shed into the bloodstream. So there are two particular aspects that we should talk about in terms of monitoring. So there's on your left side the MRD window, minimal residual disease window, which is that 2 to 8 weeks after surgery, which we want to get that first particular post-surgical sample. As you can see here, the majority, 7 out of 120, had a negative ctDNA test, and 18 out of the 34, 52%, had a positive ctDNA test. And then following that first MRD window and time frame is the surveillance window, and that is anytime 6 months post-surgery and post any adjuvant chemotherapy, kind of doing it every 3 to 6 months, and typically it's every 3 months, and then detecting for potential recurrences during follow-up, as you can see here. This is what the results that were published in ESMO, as you can see here, when you look at the all stages in the first panel on your left, all stages with ctDNA negative patients, 120 of them. Stage 2 had ctDNA negative patients, about 35 of them, and then stage 3 here at 66 of them as well. As you can see here, in patients who had received had negative ctDNA who received adjuvant chemotherapy versus in green is the ctDNA negative with no adjuvant chemotherapy. As you can see, there's very, very little difference there. If you have a CT negative, if you are not able to detect DNA in the bloodstream using this platform, there did not seem to be any real benefit for giving adjuvant chemotherapy. So it allows us to provide important insight into critical clinical questions. So you can see here from a single test, and that's that minimal residual disease time at 2 to 8 weeks post-surgery. You were able to detect the presence of residual disease that first time to be able to make that decision, as Dr. Botta mentioned, of giving adjuvant chemotherapy versus having no residual disease or no minimal residual disease that is detected. So MRD negative patients who will likely not relapse after surgery. Only 12% of patients with early stage colorectal cancer will relapse after surgery if it's a negative test. With serial sampling, which allows us to detect it over time, we're actually able to improve those results, and I'm going to go through some of that data going forward. So this is the obviously Signatera validated with a high positive predictive value and negative predictive value. If you look on the panel on your left, we have positive predictive values up to 97%. So 97% relapse rate when you have a positive ctDNA test without additional adjuvant chemotherapy. It drops from 97% down to 70% when you administer adjuvant chemotherapy in this particular setting. So obviously it's a great decision maker when you're able to utilize or make that decision to utilize adjuvant chemotherapy when you have a positive test at that first value. And then as you can see here, the negative predictive value, when you look after a single test, 12% chance of relapse after a negative single test. However, if you're then able to follow them serially, which we're able to do with this platform and to follow it longitudinally with quantifiable data, we have down to a 3% chance of relapse when you have negative testing that's done serially up to 2 to 3 years. And then this is the Signatera MRD status, kind of identifying how, from a hazard ratio standpoint, well outperforms the standard clinical pathologic risk factors in predicting relapse. So in the past, it was stage, tumor grade, MSI status. As you can see here, the hazard ratio is 0.73, 1.36, 1.55. Significant differences when you look at the hazard ratios providing the platform. Even a significant increase in hazard ratio up to 7.2 when you only do that first MRD value at 2 to 8 weeks post-surgery, 30 days after surgery in this particular case. And then it continues to go up, and obviously that hazard ratio improves dramatically when you think about serial monitoring. All right, in terms of trials, I'm going to go through a couple, then I'm going to hand it back to Dr. Botta to discuss some of the active current trials. So the Circulate US study is a sister study of the Circulate Japan study, which was done for stage 2 or 3 colorectal cancer patients, set to enroll about 2,000 patients with DFS as the primary endpoint. And obviously the goal is to guide postoperative management of colorectal cancer utilizing Signatera. This is the paradigm of the trial. Patients are tested for MRD post-surgery. If they have a positive test, they go on to either adjuvant chemotherapy or potential dose escalation of chemotherapy. If they're MRD negative, then they have an option of going on to randomize to either getting adjuvant chemotherapy in there or no active chemotherapy and surveillance, as would be compliant with current guidelines. 2 clinical studies that are prospective trials that are currently accruing, bespoke colorectal and bespoke immunotherapy or IO therapy. It's about 1,500 patients aiming to accrue in both studies in 200 sites on the colorectal cancer, 100 sites in the immunotherapy side. On the colorectal cancers, obviously the impact on adjuvant treatment decisions similar to the Circulate trial that I just mentioned, and on the immunotherapy trial, based upon the data that I presented earlier, showing clearance of ctDNA in patients who receive immunotherapy have amazing overall survival benefits, and this is looking at outcomes in that particular setting as well. And finally, I think I'm going to hand this back over to Dr. Botta to talk about Circulate Japan, which is a particular kind of three-phase trial here looking at another prospective trial looking at a large-scale registry. Dr. Botta?
Yes, thanks so much. I appreciate your explanation of the previous studies. And all of those previous studies have been positive to building towards this large prospective study, Circulate Japan. And it's a multi-armed study where we're looking at our patients who are going through their surgery for their stage 2, 3 colorectal cancer, and then being evaluated on a large-scale prospective study evaluating the previous small single institutes that looked at colorectal cancer and ctDNA and outcomes. And then in addition, what they're doing is looking at patients that are ctDNA negative, and in those patients who are ctDNA negative, randomizing them to getting no treatment, just as we discussed before. Now we're saying that the ctDNA is not only a tool to help you make your decision-making, but ctDNA may also be a binary switch to say, if it's negative, you're going on observation, and if it's positive, we want to give you your adjuvant therapy with something including Capox, as you can see from the slide. Now, there's also another arm to this study, and this is those patients that are post-op ctDNA positive. These are the patients that we would give therapy to because of their ctDNA positivity, and we're going to give them their standard of care. However, those patients who remain ctDNA positive will be randomized to receive additional oral chemotherapy with trifluridine, tipiracil, or placebo. And the idea is that with these ctDNA positive patients, will more therapy over a longer time help change their outcomes. And we can go ahead and take a look at the Galaxy registry and the interim analysis from ASCO GI 2022. So it's just going to be these patients here. And basically the idea is, can we validate that original Reinert et al. Study? Can we show with all of these patients we have now, thousands and thousands of patients, that ctDNA at a single time point, 4 weeks post-surgery, can help determine outcomes? And in fact, we can. What you can see and take away from this is that in a patient cohort that's approximately 5 times larger than what was done originally, we could see that ctDNA has a 12-month disease-free survival of 95.2% if you're negative. And if your ctDNA is positive, that drops to about 55%. And we can see that hazard ratio is extremely large, is at 13. And basically what we're saying is that ctDNA provides a positive risk assessment that these patients are going to recur, and that surgery is not all that they need. And that we can show that those patients with ctDNA negative are going to do exceptionally well after that surgery and likely don't need any intervention, and are likely those patients that were able to avoid adjuvant chemotherapy and avoid the secondary side effects that might occur with them. And what we're able to do with this is now ask some questions. So these molecular residual disease negative patients and these molecular residual disease positive patients, they can be basically predicted ahead of time whether or not they're going to have response to therapy that is positive or negative for their outcome. But do these patients benefit from chemotherapy? So say I have a patient that's ctDNA negative, and if I gave them chemotherapy, could they have an even better outcome? Can we make that 100%? Or what about these patients that are ctDNA positive? Do all of them really need chemotherapy, or is there a subset in there that may not? And these are the questions that can be teased out from this data analysis. And what you can see here is that we're able to start evaluating this information. This is the disease-free survival of these patients operable 4 weeks with molecular residual disease positivity. And what we can say is that after these patients have had their therapy for their surgery, they benefit from adjuvant chemotherapy. And that benefit can be seen across all stages. So what you're evaluating here are those high-risk stage 2 patients we talked about at the beginning of this presentation. we're looking at our stage 3 patients and our stage 4 patients. And you can see that green line is with adjuvant therapy and the blue line is without adjuvant therapy. And we can see that those high-risk stage 2 patients, if you substratify them based on ctDNA, those patients whose ctDNA that is positive, they will definitely benefit from adjuvant therapy. And you can see that that hazard ratio is approximately 9.4. Those stage 3 patients whose ctDNA is positive, and you gave them chemotherapy or not, those patients with chemotherapy benefited. You can see that their adjusted hazard ratio is 8.8. And of course, stage 4 patients, we would expect them to do better with adjuvant chemotherapy, and in fact, that's the case. Those patients with ctDNA positivity who got adjuvant therapy did do better. So what we're able to show is that providers who order this test can feel confident that that therapy that they gave to their patients was needed, and in fact, they will benefit from it. And they can base that off of that ctDNA test. Now, what about these negative patients? And this is kind of what we talked about a little bit at the beginning. Can I make them even better by giving them chemotherapy? They're already at a really good 12-month disease-free survival of 95.2%, but can we increase that any more by giving adjuvant therapy? And you can see here that with this graph, you can see that the ctDNA clearance rate is now on that y-axis. And basically the idea is that these patients at 6 months post-op, 68% of these ctDNA positive patients treated with adjuvant therapy were able to clear their disease. So basically these patients who were able to go from positive to negative definitely benefited from this. And if we look at that green line, we can see that the molecular residual disease patients who were given adjuvant therapy, about 68 cleared their ctDNA. And in those cases, we can say that that chemotherapy definitely helped those patients. It definitely provided them with the ability to clear their ctDNA, and it improved their outcome, that their disease clearance rate improved their disease-free survival, their overall survival months after surgery. Now, if we look at those ctDNA negative patients and we say, hey, listen, all right, these patients were negative, but the guidelines say that I should still treat them, and we look at that, you can say that actually it does not really improve their outcome. You can see that 12-month disease-free survival with adjuvant therapy or without adjuvant therapy is non-significant. Patients who were molecular residual disease negative after surgery provide no significant benefit from additional chemotherapy. These are the patients that might have come to us, and based on guidelines, we would have said, listen, you need to go and get Capox, you need to get FOLFOX, when in fact they did not need it and they were being overtreated. And we're now being able to substratify these patients. Now, what you're going to have to remember is that this is a registry study, and that the patients from the other arms, the VEGA analysis and the Galaxy analysis, were excluded from that. And this data will come out in the future, of course. As those patients enroll, we'll have that prospective data about whether or not you should or should not treat someone based on ctDNA alone. However, this Galaxy data is a signal that we're seeing in the evaluation of these patients that will be confirmed by these other arms. But it's starting to look like if your ctDNA is negative, that you do not need or you will not get additional benefit from chemotherapy. But if your ctDNA is positive, you actually do derive benefit from it, and it is worth the risks and side effects and complications that may occur with that. Now, we can also say that this is dynamic, right? So we looked at a specific point after surgery, 4 weeks, but we want to know is that over time, does that change the way in which we look at the ctDNA, the dynamics of it, from weeks 4 to weeks 12 postoperatively? And we can say is that, in fact, it does. In the patients who are negative and stay negative, they continue to do really well. That's that light green line at the top. Those patients continue to do exceptionally well. What about those patients that were initially positive after surgery, but we gave their adjuvant therapy and they turned negative? That's that orange line. And those patients did exceptionally well. Those patients almost did as well as those patients who had ctDNA negative after surgery. And in fact, we can think that they had a very similar trajectory in terms of their disease-free survival. Now, of course, those patients that were ctDNA positive after the surgery and they continue to be ctDNA positive at 12 weeks, they're not going to do as well. And that's because that molecular residual disease has been there. that disease has been there and it has not gone away over time. And then there's those patients in the middle. They were initially negative after surgery. Oh, good, we felt as though they cleared their disease. Excellent. However, later they had a positive test. There was a single cell there that was refractory to the therapy, or they have some residual recurrence at some point. Now, they're not going to do as well as those patients who go to negativity, but they're also patients who reduce their burden of disease with surgery up front. So they're kind of in the middle ground there, that light blue line. But what we're able to show is that these patients are able to be stratified by their outcomes over time, and we can predict who is benefiting from that adjuvant therapy, not only at one time point, but over time. And that way, as we continue to draw this test, we can start telling the patients, listen, your ctDNA cleared after you had your chemotherapy. You're in a really good group of patients. Or guess what? Your ctDNA was negative, but it did turn positive. I'm very concerned we have a refractory cell in there that's not really responding to the therapy. We need to think about changing it. Or those patients who continue to be positive over time, we can say, wow, this is a really aggressive tumor. This is a really refractory tumor. We're having a really hard time getting this under control. And it may allow us to start having these treatment discussions and decisions made earlier on, and at a point that the patients understand what we're looking at and how we're looking to change this. Now, we have to remember, these are early signs from this study. Obviously, as these arms are finalizing in the Vega and Altair trials, we'll be deriving more and more data from it. But these are the early signs that we're evaluating here, and what it means to the clinician who's ordering circulating tumor DNA. Now, what we can see here on the next slide is that this was evaluated in the stage 2 patients, and this was just presented recently and published in New England Journal of Medicine at ASCO. And we have to remember is that this is literally the case we had at the beginning that we discussed off the bat. You have this high-risk stage 2 patient, and you're kind of thinking, should they get therapy, should they not get therapy? And basically, this was the trial that kind of helped understand this a little bit better. This was a dynamic trial, the phase 2 multi-center randomized control trial, and this was done at Hopkins in Australia. And basically, the idea is that these patients with stage 2 colorectal cancer were randomized to standard of care treatment or ctDNA guided treatment. And then the outcome was looking at the endpoint of 3-year recurrence-free survival. And what we can see here is that those patients who had ctDNA guided management versus standard management, basically the patients who had ctDNA and that we helped use that to guide our decision, versus having that long conversation about T4 disease versus lymph node positive disease versus PNI versus LVI, did those patients have any difference in outcome? And in fact, they did not. Their recurrence-free survival was similar between the two, and that ctDNA could be used as a tool to help kind of stratify these patients. And it could help us avoid chemotherapy in some patients or actually proceed with chemotherapy in other patients. But the fact is that basing your management off of ctDNA or basing your management off of NCCN guidelines, there was no difference in the patient outcomes. Now, if we look at the next slide here, what we're able to see is that what about immunotherapy patients? Can we determine their outcomes and their probability of survival based on ctDNA? And there's been a couple of studies that have really looked into this. There's Bratman et al., and then, of course, we're looking at another study here, which was in Nature in 2021, and this was the IM-Vigor study 10. The idea was this was non-colorectal cancer, but this was in bladder cancer. And we had these patients who had bladder cancer, and then they went to operation, and we had evaluated their ctDNA afterwards, and we said, all right, these patients who had their surgery, they were either put on immunotherapy versus observation. And what we wanted to do was then check them with their ctDNA. And basically, did they derive any benefit from adjuvant immunotherapy? And basically, the idea is you can see from these slides and these lines on the screen that the ctDNA negative patients who got observation, the green line, light green line, at the top, did very, very well. Their probability of overall survival was obviously over 75%. Now, those patients whose ctDNA was negative basically couldn't determine if they had any disease after their surgery. They got immunotherapy in the light blue line. Did they do any better? And in fact, they did pretty much similar to those patients whose ctDNA was negative, basically meaning, you know what, the disease was really controlled after the surgery. Even if you gave them adjuvant immunotherapy afterwards, they're not going to do any better than if they had their surgery alone. So then they said, all right, well, let's look at the ctDNA positive patients. These ctDNA positive patients, they now are getting adjuvant therapy. And in fact, we can see that that light blue line does get pulled away. And those patients actually derive benefit from immunotherapy, such that after they had their surgery, we still detected there was residual disease. And when we gave them the immunotherapy, they actually had a better outcome than if we did not. And in fact, what we can say is that ctDNA positivity after surgery can predict a treatment of benefit from immunotherapy. And those patients who had ctDNA negative derived no benefit. And again, what we're able to do is withhold treatment from patients with potentially complex side effects, immune-related adverse events in patients who don't need it. But in patients who do need it, who do have ctDNA positive, we can say, listen, this is worth the cost of getting the immunotherapy. It will help you. It will provide a better outcome of survival. And this is one of the first studies prospectively showing that with ctDNA, you can use it as a way to substratify your patients, guide your decision-making, and give patients the necessary therapy they need to improve their overall survival, while also not giving it to some patients who will provide no benefit from. And at that point, what I'll do is I'll switch it over to Dr. Drazin to talk a little bit about the tumor-informed approach in molecular residual disease.
Thanks, Greg. Thank you so much, Dr. Botta. I did a wonderful job of presenting the newer trials in here. And I just have to say, and I know Dr. Botta agrees with me, is that these platforms, specifically the one that we're talking about today, has really helped us really change management of patients. And hopefully we'll be able to answer some questions you might have in real-life questions, real-world situations you might have. This particular platform is a tumor-informed approach, as you can see. And as we've been talking about, it's ultra-sensitive, specific detection of trace amounts of tumor DNA. It's detecting it in mean tumor molecules per ml. It targets the 6 variants, these clonal variants in the pathology tissue, and it's ultra deep sequencing down to greater than 100,000 x NGS coverage. They do an elimination of germline and chip mutations as part of the evaluation. So that first part of treatment takes about 2 to 4 weeks. First part of the testing when we get the pathology to the lab, identify the 16 variants to track, and then get the blood. So that first test timing is about anywhere between 2 and 4 weeks, probably closer to 4 weeks these days. And then subsequent tests longitudinally you'll be able to get results within a week of time. And the ability to do this over time serially in a quantifiable basis that's tumor informed is incredibly important and kind of leads the way in this technology and actually defines this particular platform over others on the market. So specimen preparation, this is going to be very important for our pathologists here. FFPE tissue obviously needs to fix tissues in 10% neutral buffers formalin. It's recommended to send in the most recent tissue that corresponds to the current clinical presentation. So if you're following, probably best to get your tumor tissue on the full tumor biopsy instead, full tumor resection in the setting of a resection as opposed to a small piece of biopsy. The more tissue, the better. Obviously, looking at a preferred tissue block size of 5 millimeters squared from an area standpoint, with about a greater or equal to 20% tumor content is what is potentially necessary at the minimum to get the appropriate analysis done on the Natera side in order to get the information we need so that we can track it against the plasma samples in the future. So there's 2 options. Obviously, the one on the left is the preferred option, which is the tissue block with 1 H&E slide. And then option number 2 would be a bunch of unstained slides, preferred about 10 unstained slides, about 10 micrometers thickness each. You can do 20 unstained slides at 5, but the preferred would be 10 unstained slides at 10 micrometers thick with one H&E as well. But obviously, if you could provide the tissue block, and most pathology departments will be able to send the tissue block up to Natera for analysis. And now I'm just going to turn it back up to Dr. Botta to revisit the case before we will open up the questions to the audience.
Thanks so much. I really appreciate it. So, we go back to these cases that we were kind of discussing at the beginning. How do we deal with these kind of high-risk patients that have a question of whether or not we should give additional therapy? So if we look at this patient again, 68-year-old patient, T3N0, left-sided colon cancer, microsatellite stable, MSI low, BRAF wild type, KRAS G12S. There's some high-risk features, including LVI, PNI, but otherwise low grade, 30 lymph nodes negative, no obstruction or perforation. We have to start thinking, again, how are we going to try to manage these patients? And I'll bring up that poll again. We're at 100% there for a second.
Yeah, but I consider observation and the MRD status to be about the same. So.
Okay. Very good.
5% ZLOX.
Dr. Botta, would you like to continue?
Yeah. So again, I hope that you can see from this the poll here, we have about 9% for observation, 5% for ZLOX, about 86% for MRD to help inform next steps. And the question ultimately is, at the end of the day, how does it really pertain to real life examples? Ordering the ctDNA in my clinic, I do it for pretty much all of my patients, and I use it to try to help guide my treatment and help the patients understand where they're going. So let's kind of see where this case goes. That poll still, okay, perfect. So how did this serial monitoring actually impact the course of this patient's trajectory? So you can see here on the graph, the patient has ctDNA positivity after surgery. And in this case, we say, hey, listen, actually you have T3N0. That LVI and PNI is actually quite concerning, and your ctDNA is positive. What should we do about this? And in this case, we had a 68-year-old based on the MOSAIC trial and the IDEA trial. We started saying, well, let's try to give you some ZLOX post-operatively here. I'm really concerned about the ctDNA. And in fact, we gave them the ZLOX, and their ctDNA went to negativity. And in fact, we felt improvement, and they felt improvement in their survival and their recurrence-free survival. So actually, we kept following their ctDNA basically over time, and basically we get to a point at about 14 months post-surgery where the ctDNA turned positive again. And usually in that case, what I do is if the ctDNA turns positive, I move their scans up, and I try to detect oligometastatic disease and not diffuse disease. And basically what ends up happening is you're catching it early with that ctDNA. So that imaging doesn't necessarily always show anything, and what you have to do is kind of do some serial imaging. In fact, you can see that patient actually relapsed about later, 17 months after surgery. And there's a lesion in the liver. And so what we decided to do at that point was just use radiofrequency ablation to that lesion in the liver. And then guess what? That ctDNA went back to negative. And we continued tracking them over time. And in this patient's case, what we ended up doing was using the ctDNA not only to help guide our treatment decision-making after surgery, but also guide our surveillance monitoring such that we were in a position where we caught these early on recurrence and was able to take care of it with local therapy instead of having to either wait till it's diffusely metastatic or restart systemic therapies. And in fact, we're doing this in not only the colorectal space, but at least in my hands, experimentally in other GI cancers. And I think that's really the power of the ctDNA, this early warning detection system that allows you to be alerted to the possibility of disease, and then being on the hunt for it, being ready for it, and enabling your patients to be ready for it as well, so it doesn't sneak up, and that you have a plan in place, that you're not kind of left reacting. And I think that that's really the benefit that I find from this. At the end of the day, the ctDNA is here to help us determine if patients really do need therapy after their surgery. It also allows us to know if these patients are recurring. Does that ctDNA gone from negative to positive? Do we need to be concerned that the disease is coming back? And in fact, after we did a treatment, whether it's systemic therapy, whether it's directed therapy, RFA, radiation, is the treatment working? Does that ctDNA go back down to negative? Do we see that ctDNA dynamics is downtrending? And in fact, we can feel more confident with our decision making, and the patients can feel more confident about what their prognosis is. At the end of the day, I hope that from everyone on the team here that we've been able to discuss ctDNA dynamics with you, the ctDNA test in the way that it's used clinically, and some of the prospective trials that are starting to answer some of these questions on making decisions on patients' treatment, whether it's de-escalation or escalation, in at least the colorectal population, but also other types of histologies. And I'll leave it at that and be open for additional comments and questions. Thank you, everyone.
Dr. Botta, thank you very much. And thank you also, Dr. Drazin. You've given us a magnificent lecture today in your combination. Certainly no one will ever poo-poo the advances of ctDNA anytime soon who's had a chance to participate today. Let me remind you that we will be posting the full slides and audio of today's presentation in about a week at captodayonline.com. We have just a few minutes left, and I'm going to pose a staging question to you both. I'll ask Dr. Drazin first. Does ctDNA testing actually test for stage 4 disease that's not clinically evident? And if so, do you think that this could become a test that influences the staging of disease in the future? Dr. Drazin.
Yeah, thank you, Bob. So I think what MRD testing and ctDNA testing is actually doing is, first of all, as we've talked about the particular case that we illustrated as well as the data, it actually detects the presence of this microscopic disease that would help us define whether or not it would be important to reduce the risk of relapse with adjuvant therapy, right? So adjuvant therapy on the oncology side is not preventing necessarily the relapse, but reducing the risk of relapse, reducing the risk of developing stage 4 disease. What we are doing with this type of testing, with ctDNA testing, in the surveillance mode is actually testing for stage 4 disease. And as you can see from Dr. Botta's case, that showed that yes, eventually we detected ctDNA positivity, which defined stage 4 disease recurrence in the liver, which was then treated. So it's our early warning detection system for stage 4 disease. So that's exactly correct.
Thank you, sir. And Dr. Botta, would you care to comment on that same question?
Yeah, I think that it's indeed something that I run into. You're seeing that ctDNA is becoming positive even before patients have symptoms, even before patients radiologically have any disease. And in fact, it's alerting you that there is still disease presence. Although that might be sometimes stage 4, it could just be the local recurrence at maybe a resection margin as well. Sometimes we'll see the ctDNA come back, and it might not be that there's actually diffuse disease in another organ. It might be just at the local resection, anastomosis, or maybe at something like the bed of where the tumor was removed, that there could be a local recurrence. So it definitely detects us that there's disease in the body, and then it's kind of up to us to find out where that is.
Thank you very much. And just one final follow-up for you both. I'll let you answer first, Dr. Botta. Everyone on this call, of course, is concerned about the complexity and costs of cancer treatment and therapy. Could this testing potentially decrease the cost of expensive scans for patients who do have an MRD negative test?
Yeah, it's a great question. In theory, yeah. I'll say that during COVID, when patients were unable to get to the medical facility, where we were unable to have them come into the setting for scans, I was sending mobile ctDNA draws out to their homes. And if their ctDNA was negative, we felt, definitely much more reassured that they didn't need a scan, and then they felt reassured that their disease hadn't come back. So that was definitely a positive. There's kind of two issues that we run into is that if there's a local recurrence in a sanctuary site, ctDNA may not be picked up in the bloodstream. Remember, it's a blood-based test. So things like CNS disease or peritoneal disease, you always have to be on the lookout that even if the ctDNA is negative, there still might be recurrence there. The other thing that you might find, too, is that if the ctDNA turns positive, you might move up your scans or you might order an extra scan because you're looking for that disease. So what I like to think is that, yes, in the surveillance setting, for sure, I would definitely believe that the ctDNA could help reduce imaging. And, in fact, I have found that in my own practice. During these transition points, maybe if it goes from negative to positive or a patient's having a clinical symptom that's new, at that point, that's when it actually might incite an image. But I do think overall the goal could be to reduce the amount of images that patients have.
Thank you. And Dr. Drazin, if you'd care to comment on that same question regarding scanning patients.
Yeah, I completely agree with Dr. Botta. I think that the pandemic and the issues of availability of scans would definitely led to, at least on my end, lots more testing and mobile testing for ctDNA. Based upon stage 3 disease, it's still NCCN guideline recommended to get scans periodically. When you do have a scan that's recommended every 3 to 6 months, maybe with the ability to obtain ctDNA data, we can push it to the 6 months. I think these are all questions that are going to be answered as we look at some more of the prospective data that comes out, but I agree completely.
Thank you. Thank you very much. And with that, I'll give you the last word. We have a few other questions we haven't had time to get to, but I can assure you that we have them. I will be sharing them with Natera, and we'll make sure everyone gets an answer and some contact to help you address your particular interests. So let me now begin to wrap up. I think this has really been an eye-opening and a wonderful, wonderful session today. So I really want to thank Dr. Gregory Botta of the University of California in San Diego, Dr. Noam Drazin of the Cedars Sinai Medical Center in Los Angeles. I certainly want to thank once again and acknowledge the help that Natera was in helping us put this program together with their special educational grant. And I do want to thank all of you for taking time today in a very busy schedule to join us. I trust that you've enjoyed this, and I look forward to hearing from you about it and to have you participate in future CAP Today webinars. So with that, I'll thank Dr. Botta, Dr. Drazin, I'll thank Natera, thank all of you, and with that, I will bring today's webinar to a close.